everyone. Thanks so much for joining Marilee's office hours for this month. I can't believe that we're already literally the last day of July. We thought it would be a good time to do two things, one really fast and the other really dig in more deeply into this interesting discussion going around this topic of who can participate in nationwide data exchange networks and frameworks. And the timing of this call could not have been better, because I literally have news hot off the presses. Because for those of you who have been watching the news, there was an interesting meeting yesterday in the White House. And that is probably going to have, I think, some positive impacts on, just even the topic that we're talking about today, which is good. Real quick, I want to touch base on for those of you who are participating in Carequality, and are following at all what's going on with the rollout of the new Delegation of Authority policy. I just want to remind everyone, we have just got it. That policy went into effect in May. For those of you who are onboarding new connections to the network, there is a new process. Anytime that you are a piece of health tech that is coming into a provider group and sitting next to an EMR that's already connecting that provider group to the network, there's a new business process that has to be used. So I'll just quickly tell you that we're in the middle of an implementation that started in May and won't be done until mid-September, and that's if the timeline doesn't get moved around. So we kind of have 1 foot in and 1 foot out. The biggest challenge we're facing right now is that it's just a new process. And so Zen, and working with some of our customers, I know some of you are on this call, or will be shortly. It's just that education process. So we're making sure our customers know and understand that creation of the delegation notice, who needs to sign it, and then who does it get sent to, so that the implementer, the EMR's implementer, either the EMR themselves or their implementer, can review and say, yes, you're good to go. And then Zen, acting on the behalf of the delegate, can go ahead and make that entry into the network. So it's a little bumpy right now. I think implementers are doing a pretty good job of working together to try to fill in the missing gaps of the information we don't have, so that we're all getting smarter. I wish we had had enough time to get all that information together. I think, lesson learned, we all needed about 60 days to prep before we got the requirement in place. That would have been handy, but we didn't get that. So we're learning as we go. And I will, if anyone is running into challenges with that, don't hesitate to reach out. We'll definitely be covering this topic again on my next office hours, because it'll be getting very close to final implementation steps. So we'll have more to communicate. But today we are going to dive into this whole topic of who can actually participate in two of the important data exchange frameworks that we have today, which is TEFCA and Carequality. And I think under Carequality, before TEFCA came along, people had a pretty good understanding of who could participate in exchange, licensed providers, and that's pretty clear, right? Every state licensed providers. And so so knowing who a licensed provider is, I think, is pretty easy. And then, of course, their care team, the people that are surrounding that provider and delivering care to the patient, or part of a care team. I think that was also pretty clear. And we all understood that there's business associates that come into play that might be acting on the provider's behalf. So I think it's been pretty clear up until TEFCA came out with the required treatment definition. So what TEFCA did is define two types of treatment exchange purposes. And one is just regular treatment that has a broader, more in alignment with Carequality definition of who can exchange. And the other being this more restrictive set of requirements under TEFCA called required treatment, where it explicitly states that you must be a covered entity. Now, what we're discovering is there's a lot of misunderstanding of exactly what a covered entity is. And TEFCA is really using the very strict definition that HIPAA has in that law that was created many years ago, and was basically created to make sure that we could handle electronic transmission of claims data, claims, remittances, eligibilities. It wasn't written in the world of clinical data exchange. And that is hurting this definition, because what's happening is we've got these unintended consequences where we're leaving certain important groups out under required TEFCA treatment. So just real quickly, what I'm showing here in the middle with these hexagons is under Carequality, you need to be a licensed provider and you need to follow HIPAA rules. So even though maybe you're not exactly a covered entity, but you're touching PHI, I think most people in that case assume that they're covered under HIPAA and they're following HIPAA rules. That's been our experience. But Carequality simply in their agreement, and that's in their flow down requirements, everyone who participates in Carequality exchange is required to follow HIPAA rules, and that's just how they solve the problem. TEFCA decided they wanted to explicitly narrow this down and say you had to be a covered entity. Why did they do that? Honestly, a lot of it was a reaction to the issue that occurred between Particle Health and between Epic last year. So there was, and there were some other issues too, but that was the big one that most people are aware about. And so this was kind of, in my opinion, maybe, you know, how that pendulum swings too far. I think this is maybe an example of the pendulum swinging too far. And now we have these unintended consequences. So one of the important unintended consequences, and this is particularly important for current Carequality participants today, or people who are thinking about joining Carequality, that you need to be aware that even though it appears as though Carequality, you know, you don't have to be a covered entity, and TEFCA you do. Well, there's a problem with that assumption, because one of the largest implementers under Carequality, which is Epic, took the language from TEFCA required treatment and adopted a business rule, because that's allowable under the Carequality agreement. Any implementer can implement a business rule around who they will exchange data with, as long as it doesn't violate certain aspects of the agreement, noticeably reciprocity, and you can't discriminate from one type of stakeholder to another in terms of the parties that are represented under Carequality. But Epic felt that this they could do this, and so what's happening in real life today in Carequality Network is that the kinds of connections that last year we, working with our customers, could get approved for Carequality participation are suddenly not getting through the Epic phone book review process. So they have a very diligent process they go through now. This is a little different than a year ago, where they look at every new directory entry that's put in the Carequality directory, and they do what they call a phone book review. Why do they call it a phone book review? Because Epic literally publishes something out to all their Epic facilities every week that pushes the Carequality directory updates over to those individual Epic facilities, since they're all, you know, on standalone Epic systems for the most part. And so if you don't get through Epic's phone book process, you can be in the network, that connection can be in the network, but you're not going to be able to exchange data with an Epic site. Well, obviously that's a problem for most people, because Epic is one of the, you know, that's the largest, represents the largest number of providers. So I wanted to bring that to everyone's attention, and kind of bring you up to speed with, you know, kind of, now we kind of understand that as being, you know, kind of a working problem that we're all trying to get to work around. Let's broaden this out a little bit for those of you who maybe just generally are interested in TEFCA-based exchange and who can participate. So we'll set that kind of problem statement aside. We're going to zoom out a little bit and just talk about who can participate in exchange. And this is really pretty consistent with this exception of the covered entity problem across both Carequality and TEFCA. But I do think one of the things that TEFCA has done really well, and that I'm gonna show you some screenshots of here in just a minute, is they've done a really good job of defining very specifically even the kinds of licensed providers that can participate in TEFCA-based exchange. And it's actually a bigger group than you might expect. And I think in some cases is opening up the door for new participants that we haven't even seen in Carequality. But just real quickly, I know you guys can read, but one of the requirements for both networks, which a lot of people don't know, is that you do have to be a US-based entity. So if you're a health tech vendor, I know we work with a lot of vendors that have an offshore component, but you'd have to have a license, to operate here in the US. And that's the entity that you would register if you were joining either TEFCA or a network like Carequality. You have to be a licensed provider. You could be a government healthcare entity. You could be a public health entity. You could be an entity that helps coordinate government benefits determination. You can be an individual access services provider. This is works much better if you're in TEFCA than if you're in Carequality, because in TEFCA, this individual access service provider use case is a mandatory response, and it is optional under Carequality. So you don't have much adoption, but you have a growing level of adoption happening in TEFCA as more and more providers get added to the TEFCA network. And then finally, under TEFCA, they specifically say that, people like Zen, we're an interoperability enabler, we're a provider, we're a hub, we're a piece of technology, we're a gateway. We also play a role. And I think importantly, you guys understand that, those flow down requirements from TEFCA apply to Zen just like they apply to everyone else and people like Zen. Now, when we talk about licensed provider, there's also this aspect of a business associate working with the licensed provider if they're authorized to act on behalf of the licensed provider. And then this issue specifically on a use case basis or exchange purpose basis, because the exchange purpose under TEFCA and under other networks can actually, take this big list and start to narrow it down. So when you look at the TEFCA documentation on a given use case, make sure when you're reading that policy that you're reading, are they making any changes to the definition of who can use that use case? We've got some new use cases coming along later in the year, or I guess at the beginning of 2026. And that's one of the things I'm going to be doing is really reading those they call them SOPs in TEFCA, reading those very carefully to see if they're narrowing the scope of the kinds of entities that can participate in that particular use case. I need to take a drink of water, so this is a really good time to pause for questions from anybody. And I would and Jessica, I use Jessica to let me know when someone put something in chat. So I got my full screen available to me here for my whiteboard. So I would love for you to just raise your hand and ask the question, or do not raise your hand, just turn off your mic and start talking, because I don't think we have so many people where that's going to be a problem. So feel free to just jump in, and it might be a question, or maybe it's just a comment. Michael, I see you. You represent
Marilee.
Hi. You represent a big health system, and we don't often have large health systems present in our discussion. So I'm curious your thoughts.
Well, I have lots of thoughts, but I was actually going to ask the question about yesterday's big meeting at the White House and everybody signing things and making pledges. And I was trying to figure out if the new CMS interoperability network is different or the same from TEFCA, and if you had any insights there.
Well, it's funny that you ask. I was not at the meeting, but I stayed at Holiday Inn. No, my good friends at Commonwealth were at the meeting. And Paul, we just got off a call, kind of an urgent, all Commonwealth members, we are a Commonwealth service adopter meeting that literally, I think wrapped up about 40 minutes ago. it was very interesting. And I think the answer is TEFCA is still part of the equation. They're not limiting it to TEFCA, because if you look at the scope of their announcement, it covers a lot of possible interoperability use cases. So I think that's important for everyone to keep in mind. It talks about bringing CMS and other government entities more into the data exchange picture. There was a little bit of concern early on that in the initial press releases, they weren't talking about TEFCA explicitly. That got people's attention, but apparently at the meeting, the ASTP-ONC secretary was there, and I forget all their titles, but Steve Posnack was there, and they absolutely supported TEFCA as being an important way that people can participate. And really their message though was join a network. Like, pick one. Join a network. Maybe it's TEFCA, maybe it's just Commonwealth directly, maybe it's eHealth Exchange, maybe it's your local HIE. It's join a network and start actively engaging in community-based health information exchange. I think and that question explicitly got asked to Paul, and he said that it was definitely TEFCA had a seat at the table for sure. I think other things specific to this meeting and TEFCA, and these are things that are just people trying to interpret what was said, so don't hold me to this, but you may see this administration getting a little bit more, wanting to be a little bit more guiding or influencing the direction of TEFCA. And I would say, what does that mean? I think they want to go faster. They want to encourage new use cases to get adopted faster. They want to overcome obstacles faster. They just want to go. They want more fire adoption, et cetera. So it will be interesting to see. I know that the TEFCA steering committee, or sorry, their governance committee is having, I think, their first meeting. That's a new group under TEFCA. And they're going to be looking at some of the things that feedback that they've received from ASTP-ONC. So I suspect we're going to keep seeing more news coming.
So basically what you're saying is that the CMS interoperability network is going to be federated and could encompass multiple types of networks and frameworks that we currently participate in, and in the future maybe adding new and exciting opportunities. So yes. I appreciate that answer, and at least from our perspective is that we are looking to participate and meet people where they are. So we're multimodal, so we still participate in Carequality and eHealth Exchange on those networks specifically, and we'll be going live with our TEFCA connection on Monday. So all exciting news.
That's fantastic news. Wonderful. The other thing I want to address, because this kind of got some press, and I asked this question specifically to Paul because it a little bit got I got a little worried about it. I'm sure I wasn't the only one, but it appeared in some of the press release that happened yesterday, is that maybe there was this concept of EMR sharing data with CMS, and that CMS would be aggregating data, and then that's how patients would get to their data through Blue Button. And I don't know whether that was a misunderstanding or a misinterpretation or what, but there was a big effort in the room, according to the people that were there, to say, no, this is federated. The federation is a key component. So the concept of, all the networks being federated, where they definitely want to put an emphasis on record locator services to make it easier. Not all the QHINs, for example, I don't know if everybody knows this, have record locate, EMPIs and record locator services. So while they have some requirements in that area, it isn't necessarily to the extent that you would think. So the Commonwealth, Paul felt that at least based on what was talked about in the room, the focus continued to be on, to your point, Michael, joining the network that works for you, and this idea of the data being federated as opposed to getting pulled in. On the other hand, they also recognize that there's a lot of valuable information, at CMS and in other healthcare, organizations that fall under the federal umbrella, and making that data more easily available would be important. And then I know you guys have probably seen that they feel like they have an important role to play to fix the provider identity problem. By rethinking the provider directory that currently exists, and how to make that better, and then how to leverage ILA2 identity vetting, not just at the patient level for individual access services, but also at the provider level. So that was also a big point of discussion. So again, you can see there's a lot of things that are just getting started as conversations of these are, goals, but a lot of still uncertainty as to exactly how those things get rolled out.
Yeah, and hopefully when they deal with the provider directory angle, that they don't limit it to the individual physician slash clinician, but allow for directories for organizations or departments or subdirectories, because we have a lot of routing for data that goes to departments or non-clinicians who wouldn't be in that directory, that we would need to have be able to participate, because the physicians and clinicians themselves can't always handle the amount of data that we're going to receive through those channels. And that may be a difficult piece if the directory is trying to route information directly to physicians, as opposed to organizations where patients, especially for value-based care patients, for organizations that manage that care as a team approach, as opposed to an individual physician clinician approach. So
I think I'm so excited you guys are participating in TEFCA, because I know you guys are really good at communicating with your implementer and your QHIN, which is Epic, and pushing that kind of feedback up, I think is going to be really important. I think TEFCA is going to remain a very important driver of where we go, even though maybe they're not directly implementing, because of that close association with ASTB ONC.
awesome. Well, I'll let you get back to your regular. This wasn't the Mike and Marilee show. Sorry, folks. I just.
I'm glad you brought it up.
that.
I was going to do so a little bit later, but sometimes people can't stay for the whole session. So that was all perfect timing. Great.
Awesome. Well, thank you, Marilee.
Anyone else have a question or a comment right now, or do you want me to keep going? All right, hearing nothing, we'll keep going. So I mentioned that one of the things I like about TEFCA is what a great job they did of really very explicitly defining the kinds of providers that they anticipate would be able to participate, or explicitly able to participate broadly in under TEFCA-based exchange. And I do think that this is, even though I think you have to recognize that in Carequality, as far as I'm aware, we don't really specifically define a set of providers. So it's not like we're limiting it, but I think this just kind of, if there was any if there was any debate in Carequality, we can now look to these definitions in terms of the types of licensed providers. So I think a couple of things that are important, you'll see there's home health entities, nursing facilities, community mental health, a couple of things that EMS provider, pharmacist, pharmacy, a laboratory, there's a lot of I would say, and dentists, chiropractors, so there's a lot of people here that may be a physical therapist that maybe you wouldn't have thought of, a social worker. And so this is great. And then you have all these other categories, including, federal agencies and those types of folks. But again, the thing that's kind of the limiting factor from a treatment-based exchange is this covered entity requirement. So if you look at TEFCA's treatment exchange SOP, you can tell the difference, because the regular treatment, which is not the required treatment, really doesn't have any sort of limitation language in it when it describes what that treatment exchange purpose is. But when you go down to the required treatment section, it has this covered entity language. And I'm sure many of you know that there's a number of people here on this list that in fact, are not necessarily covered entities by the strict rule of the federal language that says you have to basically be doing claims processing or doing eligibility checking through either commercial insurance or Medicare or Medicaid. That, that might leave an assisted living facility out that has licensed providers coming in, but they're not technically taking Medicaid or insurance. Those people are all participating in Carequality today, but now because of this business rule that's happened with Epic, we're not able to onboard those kind of facilities to the network without jumping through a few extra hoops that I'm going to talk about in a minute. So one of the things I want to do is brainstorm together for a minute. Can you guys give some examples of provider organizations or licensed providers that you feel are getting left out of this covered entity definition? And Jessica, I'll let you, if someone's, again, feel free to just throw it out there. If you drop it in the chat, Jessica will call it out. Nobody? Well, you're gonna make Marilee talk the whole time. You're gonna get tired of Marilee talking the whole time. All right, I will jump in with a couple, but I have had some people bring up some ones that I hadn't thought of, which is why I wanted to bring it to open it up for the group. So the ones that we've run across so far are concierge medicine providers who don't take insurance, free clinics who also might, so it's kind of like two edges of the spectrum from a medical care delivery perspective. I mentioned the assisted living facilities. Someone mentioned some of the regional HIEs have jails and prisons that they exchange data with, at the state or regional level. And that provides a really important service to the community. Anyone else, now that I've said a few examples, anyone else have any that you think of? EMS, some of the EMSs do and some don't, depending upon the contracts in the county. So if you look at this group, I think there's some pretty good clues that you might run across some of these entities. And so again, maybe if you're not participating in TEFCA, you go, oh, it doesn't really affect me. But knowing that we have this issue with Epic right now, that's why I want to make sure that we're creating awareness. So here's a few of the ones that we just talked about. So what do you do? And again, I'm seeing some people that I know are working with either our implementers or are a candidate implementer falling under Zen for Carequality. So the easiest way to check the box, if you have a concierge medicine practice, a free clinic, or maybe even assisted living facilities, is see if they're willing to sign up for an EDI service. There's lots of them out there, so they can at least check eligibility, because a lot of these providers are still delivering important primary care services, and they are they're kind of helping coordinate care amongst other covered entities, right? Even if you refer someone out to lab work or x-rays or MRI, it's probably important for you to know, even if you don't take insurance, what kind of insurance the patient has. And so we have successfully been able to use the fact that the provider is signed up for one of these EDI services to check eligibility. And we've used that as evidence that they are in fact a covered entity, because it makes them a covered entity. So that is my best recommendation for right now. Is to ask them if they have a relationship like that. And I know in the one case that we just recently did with one of our customers, the provider group was using one of those services already. And so what we did is we had the provider group take a picture of their portal that they used for that EDI service. showed their account so that we could tie it directly to the name of the provider group that we were registering in the directory. And we showed that they're using it, right? Because we're not trying to cheat the system. We're simply trying to provide evidence that even though it may say on the provider group's website that they don't take insurance, they are in fact doing an EDI transaction that qualifies them under as being a covered entity. Any comments or questions, input on that? As a process? Do people think that sounds like a reasonable approach? Do we got any thumbs up, Jessica? Because again, I can't see the comments.
I don't show any thumbs up yet.
Okay. Oh, wait, there's my chat. I got my chat turned on. Awesome. Oh, there's
Elizabeth.
some, so I'll just review the comments real quick. So Michael says it was more than an issue, and he was talking about the dispute between the two implementers, and I was using my language carefully there. He's absolutely right. Elizabeth talks about imaging and radiology. I think in a lot of cases, imaging and radiology, yeah, and then that may be who can exchange. And then certainly the extent that, imaging and radiology, you've got licensed providers in those institutions. Most of them are covered entities. There might be a few that might be private pay only. There's some interesting new technologies that are arising that just let patients go in and get a full body scan, for example, and they probably don't take insurance, but yet that body scan information could be very valuable information back to the other providers that might be interacting with that patient. So I think that's a really good point. It helps when I get my chat working. All right. So one of the things that I wanted to do to get back to the tie-in to what's happened here over the last 24, 48 hours is on the Common Will call, we talked about what does this mean? What is the administration really getting behind to push the industry to collaborate together, to move faster when it comes to healthcare data exchange and interoperability? What are going to be the real world impacts? So, and Benjamin, I see your comment, so I'm gonna come back to that. That's great. The real world impacts, we think one of the first ones may be this. There is some rumors that perhaps ASTP ONC isn't thrilled about this bifurcated treatment, required treatment definition, and that it is in fact, they've gotten a lot of feedback, I think even in the RFI responses that people did back to CMS, that is basically starting now to move us back into an information blocking world as an unintended consequence. And so, the message that I'm receiving is we've seen a problem. People have there, and I can tell you that there has been a ton of discussion about this problem on the Carequality Advisory Council, because one of the topics that we had as a group to look at in terms of aligning with TEFCA this year, which is what we've been supposed to be working on, is which TEFCA SOPs are we kind of in misalignment with, and which ones do we adopt? So just like we did with Delegation of Authority. And the second one up that we were tackling was required treatment. And I can tell you that, as you can imagine, there are a lot of existing, for example, there's over 1,000 assisted living facilities using Carequality, getting tremendous benefit out of that. And there's a pretty significant subset of those folks that if Carequality adopted required treatment as the only required response exchange purpose for treatment, there'd be a whole group of people dropped out. Same thing for concierge medicine if they're not doing eligibility checking or they can't do eligibility checking for some reason. And so that raised huge red flags. It was a very passionate debate on all sides. And when TEFCA conversations kind of got re-energized here in June, when we got the new secretary for ASTP ONC, then, and by the way, apparently he's happy to be called shoot, there was an old term for it, and now the national coordinator. Someone help me out here. There was a term that we used to use for the head of the ONC in the past that's much shorter than the new title. But when the Carequality Steering Committee sees TEFCA, oh, it looks like we're back full steam ahead with TEFCA. We're not going to dramatically change course. They kind of realized, and after listening to the feedback with people that really had a lot of disagreement on this, whether Carequality should adopt these more stricter standards, and really everyone has said we shouldn't. But what we were struggling with is, well, what should we do? Like, can we tighten it up a little? Do we list people that we know probably shouldn't be allowed? How do we enhance trust? Which that was kind of the point of all this, right? Is to enhancing the trust. And so what they've done basically now is they're tabling this alignment around required treatment definition and what we wanted to do with that, and saying, you know what? This is pushing back up to TEFCA and to the RC, the recognized coordinating entity, the RCE, and they're going to try to let them deal with it first, because if you look at some of the early announcements out of TEFCA when they first, and I think it even says it in the SOP, when they created this required treatment definition, it says we intend to come back and open this up more. This is just to get us out of the gate. And apparently what's happened is there was no coming back. And that could have just been because, TEFCA stalled out there a little bit in the first half of this year. So the good news is, certainly we found something that works for most providers. There is value in checking eligibility, and that does check the box for Epic's phone book process. And I think even better, there's a good chance that instead of Carequality aligning with TEFCA, that TEFCA may come back and align with Carequality, which will be very interesting. Not guaranteed. And all of this is just people's kind of interpreting, a bunch of different conversations yesterday in DC, but I felt like it's a good sign. I mean, the emphasis is on let's make it happen. And yes, trust is important, but at the end of the day, it's to the benefit of the patient that data can flow more freely. I want to come back to Benjamin's comment. We were talking about who might not be considered a covered entity. And Benjamin mentioned state labs performing testing. And that's a great example. I think that public health has its own use case. And so I don't know, maybe that would fall under public health, but maybe not. Benjamin, you probably know more about it than I do, if you want to comment on that.
Yeah, it's just public health. I just didn't know. I mean, if you were asking about what providers would have data and data exchange needs that also don't typically accept insurance or are not directly in the path in that particular pathway, state labs sort of came to mind. There's probably other ancillary sort of services provided around those kind of lines.
Yep.
But yeah, typically once you get outside of the hospital or the direct care environment, a lot of that data collection sort of is difficult to ascertain and incorporate.
Yes, and I do think that other side of that is expanding exchange purposes and making more of them mandatory responses. And so, public health is one that's absolutely critical. One of our one of Zen's very first customers, CRISP, which is CRISP Shared Services. They operate HIEs across the country. They originally came out of Maryland and DC. They were awarded a contract with the CDC to really work on expanding public health and data exchange, and participated in the first successful exchange under TEFCA of public health data. But again, that is still voluntary, and public health has a lot of infrastructure they need to get in place to really scale. But again, it's a step in the right direction. And I think that the other exchange purposes that we're going to see coming, and I know Bart, if you're still on, he probably had to drop off. Oh, no, I think he had to drop off. There are a number of our customers that not only support provider-based use cases, but also support, that interaction between providers and payers. And so this, I think a couple of interesting things were noted yesterday. A lot of payers signed the pledge. And by the way, there were multiple pledges. So depending on kind of what kind of stakeholder you were, the pledges were worded slightly differently. But there were a number of payers that apparently pledged yesterday to join a network. Because they've kind of been sitting on the sidelines. Some of them have been supporting some of the networks financially. I know Humana had been a long time Carequality member, but they really didn't have a use case that would allow them or any willing exchange parties, right? And so they really have kind of been, I don't think they're purposely not participating. I think they just didn't have any willing parties to exchange data with them. And that's one of the things that both TEFCA is trying to address. And then I think this overarching CMS interoperability framework is going to try to address. I would love it if somebody would bring any question to the table that you might have about either, what's going on here over the last couple of days, or any aspect of either Carequality exchange or when I say Carequality, I'm really referring to all three of the networks that Carequality knits together. So eHealth Exchange, Commonwealth Alliance, and then Carequality kind of sitting in the middle, that then connects those three networks together, as well as TEFCA, where you have the QHINs. So really, of course, those of you who've been to a lot of these know you can ask me any question. I don't always have the answer for sure, but my promise is I'll do my best to get you a response. But feel free to drop it in the chat or just start talking. Steve, and you might be eating lunch or something, but I do reserve the right to call on people from time to time. Steve Lambert, if you're able to join into the conversation, I think it would be great. You guys have been doing both eHealth Exchange and Carequality Exchange, and now just recently we've onboarded you to Commonwealth. I am really curious what you see from your perspective as a provider of a tool that many providers use to make it easier to pull, to assess the information coming back from a whole bunch of different sources. Love your comment and input on anything, really.
Okay. I mean, about the only thing I know that I'm aware of, I guess maybe I'm not quite understanding what you're asking me to give you here, but no, we've been experiencing a little bit of difficulty getting some people over the line since in the last few months, and we think that this kind of discussions you're having are part of it. That some folks aren't fitting the profile like they used to. So
Yeah.
I mean, that's probably been the biggest thing on this subject that we've experienced is we've got a few potential clients that aren't actually having a tough time getting approved. So.
Yeah, the covered entity problem is for real. And for those of you who are experiencing that pain, thank you, Steve, just for validating that. And you guys have been great to work with. You're one of the ones where we were able to get the provider evidence that the provider was, even though they were concierge medicine, if you look at their website, it was very clear they didn't take insurance, but they were actually checking eligibility, and that we used that as evidence. And that did get through Epic's phone book policy review. And so we actually got them over the finish line, but then there are certainly those that don't fit that. So I think it is for real. I have been very outspoken in our work groups, in the Commonwealth work groups and discussions, today on the Commonwealth meeting, in the advisory council, that this, it isn't just about TEFCA. It really is affecting new connections today. And that's why I personally was really glad to hear that this isn't going over well. There's many implementers that are not happy about the business role, and they don't blame Epic as a vendor. I think that again, it was that pendulum swinging back of concern about the lack of transparency in some of the connections that were added last year, and larger health systems that fill the list, the risk and liability much greater, wanting to make sure that they really knew and understood, why the networks were being used to as a source of information, and that it really fit a treatment use case. There were some very interesting conversations around, well, in some states like Texas law says that if you're a licensed provider touching any sort of PHI, you by definition, as far as Texas is concerned, are a covered entity, and therefore you must follow all the HIPAA rules. But I was told that doesn't count, and that was a bit surprising, because there's other areas of our Carequality agreement that say you must respect state law as well as federal law, right? That there are sometimes conflicts in those laws. And so that was interesting. But I feel, like I said earlier, I feel positive that maybe this is a short-term problem. If TEFCA truly makes this change and goes back to just a normal treatment definition, I think it will be impossible for these special business rules to continue to exist without getting a information blocking concern. All right.
Hey, Marilee, it's Mandy.
Oh, yes, Mandy, great.
How are you? I just appreciate you doing the quick touch base on the payer side. We've been in a ton of conversations with our payers right now around, what are you thinking? What do you want to do? And, the feedback we're getting is just, there's a lot of hesitancy around, what are they actually going to get? And, is the healthcare operations use case really going to be mandatory in February? Is that going to be pushed out? And then just like the lack of, I guess, payment structure, I will call it, of what, they're concerned on, how much are they going to have to pay for this data? And so I would just welcome any of your additional thoughts there.
Mandy, you're bringing some things up that are super important. And I see if I can real quickly pivot over to, if we look at exchange purposes, so we can kind of see what Mandy's talking about. So let me see if my computer, and I can zoom this in a little bit. So if we look at our little matrix on exchange purposes, you can see here that we even have payment as a valid use case under TEFCA. But you can see right now payment is not required, and there's this little column that says permitted fees. Yes. Healthcare operations. Yes. Care coordination, case management. Yes, yes, yes. What does that mean? It means that the people that are responding to those queries are able to charge fees. Even public health, they're saying that fees can be charged from a responder perspective, the people who have the data. And then you have this, yes, fees for government benefits. Well, I totally understand on the government benefit side, because the SSA, for those of you who don't know, under eHealth Exchange, and now I think through Commonwealth, because the federal government's doing a big change. I think this is still under eHealth Exchange, however, but they pay, I think it's $15 per chart that they pull through the network. And so this kind of started this whole concept of paying for receiving the data because there's value there. And I think that, a lot of the health systems, if the care, if the payer is pulling data for HEDIS reporting or quality measure or care coordination use cases, then they want to be able to, then the health systems wanted to be able to charge the payers for that access. Well, as you can imagine, like Mandy's saying, the payers are going like, now, wait a minute, that feels like information blocking. And I have asked everyone, including Liz at Commonwealth, what's the deal with this? How is that going to work? What are the vehicles for payment? And the answer that I've gotten so far, and I'll meet with her next week, so I'll see if there's any change in this, Mandy, is we don't know yet. Well, I mean, we're 6 months away.
Yeah, right?
So,
It's concerning to, think about what are we really doing here? And it's a big concern from the payers of what are we gonna have to pay here?
again, I tend to be a very positive person. I always think glass half full, at least as my first reaction to things. So and Paul from Commonwealth kind of validated this. I mean, his message was, okay, not everything in this administration is going great, but this piece, this healthcare, this emphasis on healthcare interoperability seems to, there were no red flags that went up, at least in the room, right? So we'll see what spins up afterwards. But he really feels that that is one of the reasons why the ASPONC may want to get a little bit more, have changes to the common agreement so they can have a little more influence. So, because right now their role is kind of veto. I can veto something that the TEFCA governance model comes up with and say, no, we're not doing that. But they don't necessarily have a vehicle to suggest. And so this is why I think the next week or two is going to be really important to stay closely with your ear to the ground in terms of what changes get announced by TEFCA, and it can take a while to get changes to the common agreement worked through. So that may be a while before we hear anything publicly, but if there are going to be changes to the common agreement, they might be allowing the federal government to have a little bit more of an influence on, what they'd like to see have done, allow them to put some pressure on, because for some of these big vendors, if that pressure isn't coming from somewhere, nothing happens, right? That's part of the reason why they're making everyone sign pledges and trying to get them on record that they're going to be part of the solution. So I think of all my years, and Mandy knows, we've been doing this a long time, and 10 years just in not 10 years just at Zen, another, 8 years at Mirth, and then I go back to the 90s of putting computers in doctors' offices in the first place. It's been a long time. I'm most excited this year in this moment because I do feel, and we were all kind of worried what would happen. I do feel that this emphasis on interoperability is super important to move us forward. Even with individual access services, which is one of the required mandated responses, there has been some slowness up to this point in even TEFCA participants doing what is already a required response. And I think that is going to be increasingly difficult to keep those barriers up for these new exchange purposes. And we are right at 1 minute left, so I want to end on time. Any final thoughts or comments, folks? I really appreciate those of you who threw in a comment, even if I put you on the spot. I appreciate you doing that. We really do like this to be interactive, so you're not listening to Marilee talk on and on. I hope the information is helpful to you. We do this every month. So we will be back next month, and I always provide some update when it comes to what's going on with the national networks, even if my topic might be something outside of that. because I know it's difficult to kind of keep track of everything that's going on. So if no one has anything else, we'll let you go.
Thank you.
Thank you, everyone.